Thank you very much. It's an honor to be here at the ASCO Review Africa to talk about an update of lung cancer treatment. It certainly has been an exciting year. Here are my disclosures. Well, the burden of lung cancer is great. As you can see, lung cancer is the leading cause of death in most countries, with worldwide over 2 million new cases and 1.76 million deaths. In the United States, we have 228,000 new cases and over 135,000 deaths. The majority of lung cancer is non-small cell lung cancer. About 15% is small cell. Tobacco, of course, is the largest preventable cause of all cancer and a major cause of about 80% of lung cancers. It's important to remember that there are about 15-20% patients who have lung cancer worldwide who have never smoked, and they have these potentially actionable mutations as shown on the slide. Of course, right on the top of the list is EGFR and ALK, and we'll hear a little bit about both of these into this ASCO update. Lung cancer therapy has improved. This is the status of lung cancer when I was a fellow almost 25 years ago or more, where we actually saw that in patients with lung cancer who got platinum-based chemotherapy, the survival curves are shown on the left, with really no survival at 2 years, not to mention 3. At 1 year, the survival was only 33% in the metastatic setting, the median 7.9 months. It was clear a paradigm shift was needed. Well, lung cancer mortality is improving. Here are some data from the American Cancer Society, which shows mortality has declined by 51% since 1990 for men, 26% since 2002 in women due to reductions in smoking. And you can see in males, the incidence has decreased at 2.6% a year, probably smoking cessation, mortality by 4.3% a year, so clearly therapies are having an effect. And incidence in women decreased by 1.2% a year and mortality by 3.1%. The FDA has granted multiple approvals. This is actually from the time of ASCO. There have been more since then. But look at these approvals: MET inhibitor, RET inhibitor, anti-PD-L1 or anti-PD-1 plus anti-CTLA-4, anti-PD-L1, ALK inhibitor, combinations of drugs with chemotherapy, a VEGFR2 inhibitor and an EGFR inhibitor. I'll show you some of these data during the course of this talk. But the approvals just are coming very quickly. So what about practice implicating lung cancer data from ASCO? Well, first there were these data on immuno-oncology combinations, the CheckMate 227 trial. This is a trial that looked at a number of different combinations, nivolumab and ipilimumab, compared to chemotherapy, compared to nivolumab. That, of course, in part 1A. And in part 1B, nivolumab, ipilimumab versus chemo versus nivo plus chemo. Part A was PD-L1 status greater than 1%. Part B, of course, PD-L1 status less than 1%. This is quite a mature trial. The endpoint was PFS in the high TMB group, greater than 10 mutations per megabase population, or overall survival in the PD-L1 greater than 1% population. Here at this ASCO, we saw the overall survival. Well, here's the overall survival in the PD-L1 greater than 1% population. And you can see that if you look at the medians, 17.1 for the combination versus 15.7 for nivolumab alone versus 14.9 for the chemo. Hazard ratio for the nivo-ipi is 0.79 versus chemo. But even more impressive than that, look at the 36-month result. You can see 33% actuarial survival for nivolumab ipilimumab. In metastatic disease, compare that to the curves I showed you at the beginning of my talk. So this is really a phenomenal result. The question is, how do you know a priori at the beginning of the trial who's going to be in this group? But this is certainly an option for patients now with PD-L1 greater than 1% who want to avoid chemotherapy. By the way, here are the data for the PD-L1 less than 1%. This does not have statistical significance because of the way the trial was conducted and the multiple comparisons that were made. But actually, the hazard ratio for the nivolumab ipilimumab is even better, 0.64, and at 3 years, again, 34%. So this CheckMate 227, the summary, I'll just go right to the bottom. Dual immunotherapy is a novel chemo-sparing first-line treatment for advanced non-small cell lung cancer. Well, if you want to give chemo still, you still can, and you can give it with the nivolumab, ipilimumab in the 9LA type trial, where you take patients with stage 4 disease and either get nivolumab, ipilimumab, and chemo, but only for 2 cycles, or chemotherapy alone. So comparing chemo combination versus chemo. The endpoint progression um, uh, uh, was the endpoint of this trial. The primary endpoint was overall survival. Well, no surprise that when you add immunotherapy to chemotherapy, it beats chemotherapy alone. The hazard ratio is 0.66. So this is clearly a positive study. Chemo is only for two cycles. Question is the toxicity. How does this compare to the very commonly used combination of pembrolizumab with chemo? Hard to say. The data look about the same efficacy-wise. Clearly some concerns that this might be a bit more toxic. And here you can see in different subgroups, low, PD-L1, 1% or more, 1 to 49 and 50, and the results look about the same in all groups. So this met its primary endpoint, and going to the bottom, CheckMate 9LA demonstrated that Nivo plus Ipi with a limited course of disease, course of chemo, could be considered a first-line therapy in this setting. What about new drugs? And everyone's saying, what's new in immunotherapy? Well, TIGIT is, and TIGIT is another checkpoint, and tiragolumab is an antibody to target TIGIT. This is a trial in the first-line setting, a randomized phase 2, 135 patients who received the TIGIT plus atezolizumab versus atezolizumab plus placebo, so atezolizumab alone. This is a drug which actually, in the Empower 110 trial that was published in the New England Journal on October 1st, actually showed us that it was improvement over chemotherapy. So now it's a combo trial. The endpoint of this is co-primaries of overall response rate and PFS. Well, here's the overall response rate in the intent to treat population, the full population. It's higher for the TIGIT plus atezo versus atezo alone, 37 versus 21%. In the PD-L1 greater than 50% group, 66% versus 24%. And in the 1 to 49% group, 16% versus 18%. So it looks like the effect of this drug on response rate is seen, but only in the PD-L1 high group. And the same is seen for PFS. The ITT is on the left. This is what we saw going into ASCO in the ASCO book, has a ratio of 0.58. Actually the median's only improving by a little bit, 3.88 to 5.55. The curves seem to come together a bit at the median. But if you look at the PD-L1 greater than 50% group, the hazard ratio is 0.3. In the 1 to 49 group, as you would expect, 0.89. So it looks like in the high PD-L1, there's something here. And this trial has now gone to a phase 3, the Skyscraper trial for PD-L1 greater than 50%. What about targeted therapies? Well, targeted therapies are all the rage, and we're dividing up that pie, that 20% or more of the pie, maybe a little higher in Asian countries, and you can see all the different targets and drugs that we have available in this disease. What's new at ASCO this year? Well, ADAURA, and this was a trial that I presented. I was very honored on behalf of my co-authors and the steering committee, Dr. Wu and Dr. Suboy, to present ADAURA as late-breaking abstract 5 at ASCO. Patients with completely resected stage 1B, 2, and 3A non-small cell lung cancer with or without adjuvant chemotherapy. The key inclusion criteria, they had to be greater than 18 years old, confirmed primary non-squamous non-small cell lung cancer, EGFR mutation of one of 2 types, brain imaging was done pre-trial, and the maximum interval between surgery and randomization was 10 weeks without adjuvant chemotherapy and 26 weeks with adjuvant chemotherapy. Patients were stratified by their stage, their mutation status, and their race, and randomized to osimertinib at the standard dose of 80 milligrams or placebo. Planned treatment duration 3 years or until progression. Follow-up, as you can see, was quite frequent, every 12 weeks, and then every 24 weeks after that. The primary endpoint, disease-free survival. I did not expect to be presenting at ASCO this year. The trial was not even having an efficacy review in the early part of the year. It was being reviewed for safety, but the safety committee noticed that there was a large efficacy benefit, and they unblinded the trial early. The trial was powered for a hazard ratio of 0.70, a 30% improvement. Keep that in mind when I show you the data in a moment. Secondary endpoint, disease-free survival in the overall population with landmarks at 2, 3, 4, and 5 years, overall survival, safety, and quality of life. As I mentioned, because of the IDMC, it was unblinded early. Look at these data. Here's the primary endpoint, stage 2 and 3A disease, R0, complete resections. The blue curve received osimertinib, the yellow placebo, hazard ratio 0.17, and 83% improvement. It's 33% mature, so it still has a ways to go, but not bad. 11% mature in the osimertinib, 55% in the placebo. At 2 years, 90 versus 44%, 90% disease-free versus 44%, a 2-to-1 differential. Now, when you add in the 1B patients, this is an overall analysis that was planned, not the primary analysis. 1B patients, of course, do pretty well on their own. You can see that 89 versus 53% at 2 years, and the hazard ratio not much different, 0.21. Actually, in an updated analysis, it came down to 0.20, and the analysis continues. So clearly, osimertinib versus placebo, much better. Here you can see it by stage. As I mentioned, in the stage 1Bs, hazard ratio 0.5, the stage 2s, 0.17, the stage 3, 0.12, works in all 3 stages of disease. So adjuvant osimertinib will provide a highly effective, practice-changing treatment for patients with stage 1B, 2, and 3A EGFR mutant non-small cell lung cancer after complete tumor resection, with a 79% reduction in risk of disease recurrence. Here's the DESTINY trial. The DESTINY lung trial was quite an interesting study, an open-label, multi-center phase 2 study. Patients with unresectable metastatic non-squamous lung cancer, relapsed or refractory to standard treatment, HER2 expressing or HER2 activating mutation, no prior HER2 targeted therapy, and this is an antibody drug conjugate against HER2. So the first cohort, HER2 expressing disease, and what was shown at ASCO was HER2 mutated patients treated with this. And look at these data with the ADC, almost every patient, again, only a couple % of lung cancer, but look at that waterfall and look at the response over time with most patients ongoing. So it's looking quite promising. And here's progression-free survival and overall survival. You can see the progression-free survival, the median is 14.0 months, which is quite high in a refractory lung cancer population, as I'm sure most of you know, and the overall survival not reached. These are confidence bars, single-arm trial. So the DESTINY trial demonstrated clinical activity in the interim analysis with high response rate and durable response in patients with HER2 mutated non-small cell lung cancer, a response rate of 61.9%. Trials continue. KRAS, all the rage right now with drugs from Amgen and Mirati, thought to have been undruggable. Well, I guess not undruggable anymore. Why? Because of new science that found a way to bind a molecule into the GTP binding pocket. And David Hong from MD Anderson presented Codebreak 100, durability of clinical benefit of biomarkers in patients with advanced non-small cell lung cancer treated with Amgen 510. This was actually ESMO now. We're moving into ESMO. Here you can see this drug. It has a name now, Sotorasib, a KRAS G12C inhibitor. This is about 12 to 13% of lung cancer patients. Highly selective, first in class, very active. So you can see the trial was a phase 1 trial, multiple dose cohorts, 180, 360, 720, 960 milligrams. Then once dose escalation was done, a dose expansion was done. Here you can see tumor burden change from baseline. The green are the patients with 960, the ultimate dose that was recommended for phase 2. But you can see, here's the response line. You can see the response rate here is quite good, quite significant. If you look at durability of clinical benefit and progression-free survival, you can see that the median, the confirmed PR, N equals 19, and the duration of response, median 10.9 months. Patients with stable disease, the median is 4 months. The median PFS is 6.3 months for this drug. So above 6 months, I think that's reasonably good. There was even a patient who had a brain metastases that responded. This patient had radiation, however. So I promised a post-ESMO bonus, and I actually started it earlier there with the KRAS. But here's Keynote 24. This is the first trial of pembrolizumab versus chemotherapy, 305 patients. We first saw this about 4 or 5 years ago. Patients received pembrolizumab versus chemotherapy, but they could cross over to pembrolizumab. The important thing about this trial is everyone had PD-L1 greater than 50%. And these data are extraordinary. 31.9% 5-year survival, pretty much actuarial 5-year survival. So if you're the right patient on this trial, and the question is, what about the rest? But 31.9% with PD-L1 50% are alive at 5 years. Hazard ratio remains 0.62, similar to the first report. So this, I think, really is historic data and really shows how the field has come so far in the last decade. Here's more ADAURA. So we had more ADAURA at ESMO. Now we're looking at sites of recurrence. Everyone asked about ADAURA. Okay, you have an effect on DFS, but what about overall survival? Well, overall survival is a mixture. We're waiting for it. But while we wait for it, what about looking at exploratory analysis for brain disease? Because the whole essence of these drugs is to prevent metastases to distant organs like the brain. And as such, here you can see sites of recurrence, and you can see 11% of patients recurred in the osimertinib arm versus 46% in the placebo. And you can see, as you would expect, recurrence in the lung, the lymph nodes, the CNS, and the bone. 10-to-1 increase in CNS recurrence for those of the patients who were not on osimertinib. So osimertinib was preventive. And you can see on this slide a couple of pieces of data. I mentioned CNS recurrence 10% to 1%. As you can imagine, there was much more distant recurrence in the patients who got the placebo. And here's CNS disease-free survival. Look at this here. Hazard ratio here was 0.18. These are patients who got osimertinib versus the control. Clearly a benefit. Then if you look at conditional probability of CNS and non-CNS recurrence, you can see that it's much lower for the patients who get the osimertinib versus the placebo. It's clearly working as expected. And I have no doubt that when the survival is reviewed in a few years, it will have an effect on that. But that, of course, needs to be studied. So in ADAURA, adjuvant osimertinib demonstrated a highly statistically significant and clinically meaningful improvement in disease-free survival in patients with stage 1B to 3A, EGFR mutant non-small cell lung cancer. Patients who received osimertinib had fewer local, regional, and distant relapses than those who received placebo, with a lower incidence of metastatic disease in those patients with recurrence, including fewer CNS recurrent events. The adjuvant osimertinib demonstrated a clinically meaningful improvement in CNS DFS, hazard ratio 0.18, 82% reduction, and CNS disease recurrence was less likely with osimertinib than placebo. Here's the CROWN study. Let's talk about some other targeted therapies. And this is an ALK inhibitor, a new generation ALK inhibitor, also known as lorlatinib, versus crizotinib, 1-to-1 trial. Lorlatinib versus crizotinib, the third generation, so to speak, drug. Primary endpoint PFS. Patients with stage 3B to 4 disease, no prior systemic therapy, performance 0 to 2, asymptomatic or untreated brain metastases were permitted, and but they had to have an extracranial target lesion. Here you can see the results. Primary endpoint PFS, lorlatinib versus crizotinib, hazard ratio 0.28. This new drug seems to be a lot better in terms of PFS than the old drug. Look at the medians here, 9.3 months versus not met. Constantly ratcheting up to better, more specific drugs, very specific drug. And here you can see intracranial overall response. And here you can see that 66 versus 20% lorlatinib versus crizotinib in patients with measurable or non-measurable brain metastases at baseline. Patients with measurable brain metastases at baseline, 82 versus 23%. And safety, there were some unique toxicities in this drug, but for the most part, you can see that the grade 3-4 AEs were a little bit higher with the lorlatinib than the crizotinib, but clearly still well tolerated. So conclusions, lorlatinib resulted in a significantly longer PFS, significantly higher overall and intracranial response rate, and improved quality of life compared to crizotinib. I'll skip this. I had this twice. I apologize. And with that, I'll stop. And thank you very much. It's been a pleasure to be here. Very exciting data at ASCO and ESMO this year. Thank you to my colleagues.